Hello, everybody. We'll just give 1 minute for everyone to join. Welcome. We'll begin now, I think. So good morning, good afternoon, good evening to everybody here today, and especially to those who've joined from far away or from early in the morning or late in the evening. Thank you for joining the WHO EPIWIN webinar today on integrated Sentinel surveillance for influenza and other respiratory viruses, standards and implementation. For those of you who are new to EPIWIN, it stands for the WHO Information Network for Epidemics. And the goal is to make science understandable, accessible, and actionable for the public and decision makers, and everyone who starts here. Today, we have a very exciting team to explain to you about the new integrated surveillance. You'll be having opening welcome remarks by Dr. Wenqing Zhang, who needs no introduction in the influenza world. She's the lead for the Global Influenza Program at WHO. Then Dr. Aspen Hammond, Technical Officer at WHO, will be providing a presentation on the integrated surveillance. He'll explain the objectives, case definitions, sampling strategy, data collection, reporting, followed by Dmitry Pereyaslov, who will talk about the algorithms, assays, and genomics for integrated surveillance. After that, we'll have a Q&A moderated by Dr. Siti Hrobi, and your questions will also be answered. And of course, in between, we have you participate, and we will be asking you for your views. Before I hand over to Wenqing, the routine housekeeping, this is being recorded, and the recording will be shared on our website and by email to all of you. Please put your questions, those of you who are veterans of EPIWIN will know, please put your questions in the Q&A box, not the chat box, so that we can see it more easily. However, we would love to know more about you, so please introduce yourself in the chat box. We'd love to hear your opinions on chat, but please keep it positive, constructive, and to the topic. We will remove anyone who is negative or abusive in any way, but we look forward to hearing your views. Without any further ado, then, I would like to hand over to Dr. Wenqing Zhang. Over to you, Wenqing.
Thank you so much, Supriya. I hope everybody could hear me, and I hope you can also see me as well. First of all, I really would like to welcome everybody to this webinar. From the participant list, I've seen actually many familiar names, long-term colleagues from GISRAS and also from surveillance worldwide. So very nice to so-called see your name in this webinar. This webinar, we are going to focus on the standards and the implementation of the integrated surveillance for influenza and other respiratory viruses by GISRAS. GISRAS, the Global Influenza Surveillance and Response System, since 1952, has been evolving, growing. And now, as of today, we have 160 national institutions in 130 member states. Taking this opportunity, I would like to thank a lot of people, generations of scientists in the world, from developing and developed world. It's the same, like from hosting countries, from partner agencies from both private and public sectors, because we work jointly to make it happen, to make GISRS a good global assets today. So the capacity and capability of GISRS has been leveraged for other public health priorities. We all know that since 2015, RSV has been added to this influenza platform GISRS. And again, taking this opportunity, I would like to thank Bill and Melinda Gates Foundation for their support on the RSV efforts. And then, with the outbreak of SARS-CoV-2, GISRS capacity and capability was swiftly leveraged from laboratory in the countries to the global mechanisms, for example, EQAP shipping mechanism, even the influenza genetic sequence data sharing platform, GISAT. All of these mechanisms were swiftly leveraged for COVID-19 pandemic response. Notably, since March 2020, SARS-CoV-2 has been systematically included in the ongoing influenza surveillance, and thanks to the partners. Especially, I would like to thank the US CDC, because US CDC develops a multiplex influenza and SARS-CoV-2 tailored to the existing influenza platform to make the integrated surveillance possible. Now 4 years passed. SARS-CoV-2, which has already established in population, it needs to be monitored continuously. By default, GISRS stands in, and GISRS by default provides a sustainable, highly functioning global platform to monitor SARS-CoV-2 as well as non-influenza viruses like RSV. With SARS-CoV-2 and RSV being added to the influenza surveillance platform GISRS, there is a need to standardize the global operation so that the quality and efficiency, which has been labeled to GISRS influenza surveillance in the past half century or more than half a century, can also be developed for other respiratory viruses that GISRS takes on. While there have been standards for surveillance of influenza, SARS-CoV-2, and RSV individually, so we do have such standards in place, this is the first time that the WHO has developed the standards for integrated surveillance, looking at the viruses under GISRS at the same time. So taking this opportunity, I would like to thank GISRS members, epidemiological surveillance departments in countries, global experts in supporting WHO in developing these global standards. In this webinar, we'll introduce the standards and we'll also introduce the implementation, followed up with a Q&A session. And with this, I hand over to Dr. C.D. Herf from the Global Influenza Program to introduce the speaker and run the rest of the agenda item. So let me just stop here and hand over to C.D. Herf.
Thank you, Wenqing, for that. I think we have quite a line of speakers on this, speakers who have been involved in this whole process, along with many of you over the last 1 year through the many consultations that have taken place in developing these standards. So we have Aspen, who will go first. She'll talk more on the Sentinel side, the epidemiological aspects of the standards, as well as Dimitri, then who will talk more on the laboratory. And then we have a session which will be open for to answer some of your queries that you may have. So let me ask Aspen, who's part of our Global Influenza Program at WHOHQ, to go ahead.
So before we go to Aspen's presentation, we'd like to hear a little bit from you. So here we go. We'd like to know whether what you think, true or false. It is recommended to do surveillance for acute respiratory infections year-round. Do respond, slido.com, hashtag 1974468. Hashtag 1974468 at slido.com or scan the QR code. Why are we not seeing that? Why are we not seeing this? Thank you very much. We now hand over to Aspen.
Great, thanks so much, Supriya and Siddhi, and it's a pleasure to be able to present today on the integrated surveillance standards. This is guidance that's just been published and was a long process of updating, thanks to many of you who are also joining us today. So we really appreciate this as a global effort. Next slide, please. Okay, so what I wanted to start with is to first address the surveillance objectives, the integrated surveillance objectives as laid out in the integrated surveillance standards document. These are categorized into primary and secondary objectives. As a primary objective, Sentinel surveillance should provide year-round syndromic surveillance data for monitoring the epidemiologic characteristics of acute respiratory infections. Additionally, in most countries, patients with an acute respiratory illness are identified, may present and are identified at Sentinel sites, and these provide a source of clinical specimens for the systematic and integrated testing for influenza, SARS-CoV-2, and RSV. And this helps us to achieve the second primary objective, to monitor the virologic patterns and characteristics of circulating viruses that are causing these acute respiratory infections. So in this guidance, all countries are recommended to implement Sentinel surveillance for influenza and SARS-CoV-2 at the minimum as part of expanded GISRs. Countries may consider integrating RSV and other respiratory virus surveillance based on their national priorities, objectives, capacities, and available resources. And these Sentinel sites, together with the GISRs lab that are conducting the virologic testing, provide a platform and tools and evidence that can help guide public health action, decisions, and interventions. GISRs laboratories can also support event-based surveillance, so can be involved in the investigation and detection of respiratory disease outbreaks, including cases and clusters associated with novel viruses. There are secondary objectives described in the guidance as well that not all countries may prioritize, but this includes objectives like monitoring clinical severity of acute respiratory infections, identifying high-risk groups or settings, and also providing a platform for more specialized or enhanced surveillance or investigations. It's important to say countries should define and prioritize their primary and secondary objectives for surveillance of influenza, SARS-CoV-2, and RSV, again, based on their own priorities and resources. It's recommended that countries meet their primary objectives through the Sentinel surveillance for acute respiratory infections and illnesses, and also the laboratory testing for influenza, SARS-CoV-2, and some countries where it's prioritized RSV. Important to note also, countries may have other surveillance objectives that are not listed here. Next slide, please. So we're really happy to say that the guidance that we've been working on has just been published. The link is here. You can see an image of the cover. And this updated guidance stands in as the new guidance for integrated surveillance, as well as the influenza surveillance standards. So it supersedes that prior guidance. We tried to put all the important information into one document to make it easier for you to access and follow. Next slide. So what is new? What are the updates in this guidance? Just to summarize some of the key messages and updates in this version, this is based on the primary objectives that I just reviewed, that were discussed with many different experts and groups doing surveillance. Again, we acknowledge there may be additional objectives for surveillance. This guidance also goes into a bit more detail on how many samples to test, a bit of the size of the Sentinel surveillance system in a country. It maintains the core surveillance standards of influenza, as I mentioned before. And it builds on previous versions of integrated surveillance guidance that we've put out. Importantly, it integrates RSV. There's a bit more updated and additional information on case definitions, sample size requirements. There's a bit more information on considerations in selecting Sentinel sites based on the number of patients that might need to be seen. And there's also a strategic shift towards the reporting of case-based and more age disaggregated data to WHO regional office and global reporting platforms. Next. So the guidance I think is very well organized into different chapters, and one chapter is on case definitions. So the question comes up, which case definition to use in this era of multiple respiratory viruses circulating, causing similar syndromic illness. I think it's important to say that Sentinel surveillance is not intended to capture all cases of acute respiratory illness, but we're trying to use a standardized case definition for consistency and comparability. So the use of the influenza-like illness case definition and the SARI, the severe acute respiratory infection case definition, are well established and are recommended to efficiently capture enough cases to achieve the primary objectives of integrated surveillance as I went over in the first slide. The guidance also gives a bit of information on the use and recommended situations when countries may consider broader and more sensitive case definitions, such as an extended SARI case definition in the inpatient setting, or an acute respiratory illness definition in the outpatient settings. And these may be preferred for objectives that might be related to time-limited studies, such as disease burden estimation, or where RSV may be a priority virus for surveillance. Next slide, please. Another section that addresses an important question is how many specimens to test. So again, it's recommended to continue testing for these viruses year-round. The recommendation at the national level, so for the country level, is to aim to test around 50 specimens per week from outpatient settings, so using the ILI or the RE case definition, and similarly to test at the national level per week around 50 samples from inpatient settings or using the SARI case definition. And we know that this is a high target, may not be achievable in all countries, but these are the targets, and at a minimum to try to test at least 50 specimens per week at the national level from these systems combined. And there's also additional considerations in the guidance if RSV is a priority. So how many samples to test if RSV is your priority. Next, please. And then the next question is which patients to choose for testing. So again, as I mentioned, we're using these standard case definitions. We're not trying to capture every case, and it's not even feasible to test all patients who meet the case definition, but it's important to have a random sampling strategy to collect samples from the cases who do meet the case definitions. So it's important to say that a predefined sampling scheme that minimizes bias should be in place for determining which patients would be sampled for further virological testing. Next slide, please. And then another important part of the guidance is to look at the size of the Sentinel system. There is no recommended targeted number of sites in the Sentinel system. Rather, the guidance is trying to give an emphasis on having a Sentinel system which provides good quality data rather than a large amount or a quantity of data that may not be as good quality. So really emphasizing the quality over the quantity. And through some simulation exercises, we've looked at how many patients might need to be seen a week, again, at the national level. So the number of patients that might need to be evaluated for these case definitions, and looking at around over 1,000 patients per week, again, at the national level, will likely enroll enough patients to meet the testing goals as I went over and meet these primary surveillance objectives. In the guidance, there's also some considerations for selecting Sentinel sites, which ones to prioritize. And I think the key characteristics of sites are that they should be representative of the population under surveillance. Again, emphasizing the collection and reporting of good quality data in a timely way, and that that they can perform surveillance in a sustained manner. Next, please. So the next pieces of guidance that I wanted to review were data collection and reporting. So the systematic collection and weekly reporting of good quality surveillance data in a timely way is really crucial for situation awareness, looking at risk assessment, and looking at evidence-based public health decision-making. So collecting, again, good quality data in a consistent and timely way to help you analyze the situation and make the interventions and decisions that you need to make. So the guidance, I think, very clearly outlines what data should be collected at the Sentinel site level, what information should be collected from patients from whom a specimen is collected, and what information should be collected from the laboratory doing the testing. And I think one key thing to emphasize here is that we're trying to make trying to advocate for the linking of laboratory data with the patient data whenever it's possible. So having a information system that will allow you to link patient information with the laboratory testing with the EPI data will be really helpful in doing the analysis of the data. Next slide, please. So this is very closely linked to the data reporting. It's really important to have a good analysis and use and reporting of the data within the country to your stakeholders and different audiences within the country. But it's also important to report this data to WHO, again, through regional or global platforms, again, in a timely and consistent way. So the guidance outlines the timing of reporting. So reporting weekly by Thursday of the week following the end of the week the data was collected from. The guidance gives good recommendations and instructions on reporting of aggregate syndromic data, again, for each case definition and by age group, and also the reporting of the virologic data. So again, aggregated data by age group and case definition as possible. And again, just wanted to mention that there is a shift towards moving towards case-based reporting. So that is also discussed in detail in the guidance as well. And we'll be providing more information on that. The specific age groups to report on are given in the guidance. So I haven't listed them here, but I would refer you to the guidance for more information on that. Next, please. And this is the slide I will conclude with before passing on to my colleague, is just to emphasize the importance of monitoring and evaluation of surveillance systems. The guidance goes into detail on continuous monitoring, so what you should do on a regular basis, looking at data quality and completeness, and also what you should do periodically, looking at one Sentinel site or part of the system or all of the system on a periodic basis, especially if you've made some changes to the system or thinking about making changes to the system. These kind of periodic evaluations are important. I'll pass to Dimitri to conclude on some of the laboratory aspects.
Thank you, Aspen. Let me continue with the laboratory aspects of the guidance. Table 5 on the right-hand side shows the types of clinical specimens recommended for detection of influenza SARS-CoV-2 and RSV. It's recommended to collect upper respiratory tract specimens, for example, nasopharyngeal, nasal, oropharyngeal swabs. Please note that saliva, oral fluid, and sputum are not recommended for routine surveillance due to practical challenges and uncertainty in accuracy for influenza SARS-CoV-2 and RSV detection. Saliva may be used in specific scenarios, for example, outbreak investigation in children, but requires further research for routine use. Please use viral transport medium or universal transport medium for specimen collection and transport. These are well recognized for their effective viral preservation qualities and enable the culture of influenza viruses, RSV and SARS-CoV-2 for characterization and vaccine strain selection. In absence of VTM or UTM, PBS or molecular transport medium or similar may be considered for molecular testing, but not for virus isolation. Appropriate storage, transport, and handling for specimens are important to maintain virus integrity. Store specimens in VTM at 248 degrees Celsius and transport to the laboratory within 72 hours. If specimens cannot be transported or processed within 72 hours, they should be kept frozen at or below -70 degrees Celsius and transport them on ice or dry ice. Avoid freeze and thaw cycles to prevent degradation of the virus and false negative results. Each specimen should be divided into aliquots for additional testing, retesting, or archiving prior to freezing at -70 for long-term storage. Specimens should also not be stored in standard household freezers at -20 with a freeze-thaw defrost cycle. Next slide, please. So the complexity of a multi-pathogen test requires different testing algorithms based on the type of system and data readout. Real-time PCR is recognized as the gold standard for detecting influenza SARS-CoV-2 and RSV. Laboratories are encouraged to use validated singleplex or multiplex PCR kits. Multiplex assays are preferred because they offer significant saving on cost, labor, and specimens by allowing simultaneous detection of multiple pathogens in one test. The test must demonstrate high sensitivity and specificity for accurate surveillance. Regardless of the algorithm employed, all influenza-positive specimens should undergo subtyping and lineage determination, and where RSV testing is implemented, RSV typing should be conducted on all RSV-positive specimens. GISER's laboratories receive supplies for influenza surveillance free of charge through the International Reagent Resource, IRR, developed and supported by the WHO Collaborating Center on Influenza at the US CDC in Atlanta. And additionally, national influenza centers in low and middle income countries are also being offered enzyme and extraction kits to support Sentinel tests. And Global Influenza Program is also working with WHO regional offices on supporting NICs from priority countries with ancillary reagents and sampling collection kits. Quality assurance is critical for ensuring ongoing performance monitoring. Each test run should include well-characterized positive and negative controls to ensure the accuracy and reliability of the results. To monitor assay performance, laboratories should regularly participate in the annual GISER's External Quality Assessment Program, coordinated by the WHO Global Influenza Program, or in another external quality assessment initiative. Antigen testing is not recommended for use in surveillance. While useful for clinical diagnosis, it's not recommended for surveillance due its limitations and the lack of suitable matrices for virus characterization if antigen tests are used. A second specimen should be collected for surveillance and stored appropriately. Next slide. The testing algorithm below are for two preferential testing approaches, one for influenza viruses and SARS-CoV-2, and one on the next slide for RSV. The decision on the algorithms to be used should be made based on the epidemiological situation, available resources, and national priorities. This slide presents step-by-step algorithm for testing respiratory specimens for influenza viruses and SARS-CoV-2. The first step involves testing a respiratory specimen, followed by a subtyping and lineage determination for positive samples for influenza. If both influenza and SARS-CoV-2 are negative, further testing for RSV may be needed. Molecular and sequencing results should be submitted to databases such as Respimart and GSAID, respectively, for global data sharing. I would like to emphasize that it is important to perform subtyping and lineage determination for all influenza-positive specimens and be vigilant for emergence of influenza viruses with pandemic potential. Recently collected representative influenza-positive specimens, including all types, subtypes detected, should be shared with WHO collaborating centers for detailed antigenic and genetic characterization in a timely manner as standard NIC function. This is done free of charge through the WHO Shipment Fund. Laboratories that do not have in-house SARS-CoV-2 sequencing capacity should contact a WHO COVINET laboratory for genetic characterization. Next slide. So this testing algorithm for RSV mirrors the algorithm for influenza and SARS-CoV-2, starting with testing respiratory specimens. RSV positive samples should be subtyped and sequencing performed if necessary. If RSV testing is negative, but clinical suspicion remains, then other respiratory pathogens, including influenza and SARS-CoV-2, should be tested to rule out potential infections. Laboratories that do not have in-house RSV sequencing capacity should select a subset of specimens to forward to WHO RSV reference laboratory for genetic characterization. The shipment of specimens for RSV genetic characterization is recommended up to twice a year, preferably in the middle and at the end of RSV epidemic. Just like influenza and SARS-CoV-2, data should be uploaded to platforms such as WHO Respimart and GSAID. Additional testing algorithms based on assay types also available in the guidance document and described in the Annex 6. Next slide, please. So genomic sequencing section. So the sequencing of positive specimens that are systematically collected from Sentinel surveillance is vital for monitoring virus evolution and spread. Additionally, targeted sequencing from outbreak source specimens contributes to the timely detection of novel variant viruses. Then selecting specimens for sequencing, it's important to represent various age groups, times, and geographic locations to capture potential virus variations during the epidemic. Laboratories should access the optimal PCR-CT value cutoff for their procedures. So a general guide is that specimen with a CT value of less than 28 cycles are likely to yield good sequencing results. Sequencing should be conducted on as many influenza and SARS-CoV-2 PCR-positive Sentinel specimens as resources allow to meet the objective of genomic surveillance. As a minimum standard, sequencing of at least 15 specimens per week is recommended. This sample size allows for detection of virus variants or genetic clades circulating at 5% within the community with a 95 confidence interval from 1 to 27. For greater precision accumulated over the month, 60 sequences will provide you with a narrower confidence interval. During the weeks when fewer than 15 Sentinel specimens test positive for influenza or SARS-CoV-2, it is important for laboratories to sequence all positive specimens detected. This ensures that laboratory maintains sequencing capacity even if the virus circulation is low. In cases there are not enough Sentinel specimens, laboratories should use a random selection of positive specimens from non-Sentinel sources, ensuring that they meet the ILI-ARE or SARI case definition. It's also critical to strive for balanced representation across age groups, geographical regions, and clinical spectrums. And ultimately, increasing the number of specimens sequenced improves the accuracy and precision of prevalence estimates, contributing to better informed public health responses and surveillance efforts. A sequencing strategy for RSV has been also developed separately by WHO, based on defining priority objective for RSV sequencing, evidence review, and RSV genetic data analysis. The upcoming practical consideration for RSV Global Genomic Surveillance document is intended to be used in conjunction with the guidance provided in this document today. Next slide. So this slide summarizes the general laboratory workflow, starting from molecular testing, then uploading data to Respimart, sequencing, and then uploading genomic sequence data to GSAID or another publicly accessible database. And as a last step, the detailed genetic and antigenic characterization of representative circulating influenza viruses is a foundation of vaccine virus strain selection and the subsequent development and production of influenza vaccines. Therefore, it's important to regularly ship samples to WHO collaborating centers on influenza. Next slide. And the key points from WHO guidance document on integrated surveillance. The first is systematic and standardized sample collection to ensure adequate sampling and collection of clinical and epidemiological data for influenza, SARS-CoV-2, RSV, and other respiratory viruses. And the goal is to have representative and timely samples without compromising on standardization or quality. Second is pay attention to timeliness, including the time from sample collection to reporting. Meet core surveillance objectives. Aim to collect a minimum of 50 to 100 Sentinel specimens per week from patients meeting ILI-ARE and SARI case definition, and year-round sampling is recommended if resources permit. And again, focus on quality rather than on quantity. Use suggested testing algorithms provided in the guidance. And laboratories should consider genomic sequencing of as many influenza and SARS-CoV-2 positive Sentinel specimens and try to sequence at least 15 of each per week. Timely reporting is critical. So for surveillance data, weekly reporting to Respimart by Thursday of the following week is recommended, and sequence data should be uploaded quickly and regularly, for example, weekly or bi-weekly to GSAID or other publicly accessible databases. And please ensure to select GISRs under the network field and Sentinel surveillance under the sampling strategy field in GSAID when you upload your data. The overarching goal is to translate surveillance data into local, national, and global actions and policies. GISR's laboratories are uniquely equipped to deliver integrated surveillance and have opportunities for technical and financial support from WHO and partners to showcase their work. And these key points highlight the importance of standardized surveillance practices, timely reporting, and vigilance in detecting unusual viral activity, contributing to informed decision-making and global health policies. So next slide. So we would like to thank GISR's laboratories for their significant contribution and dedication to this integrated surveillance approach. Thank you.
Okay. Thank you, Dimitri. Thank you, Aspen, for this this overview of the standards and the implementation. So I think we have quite a few questions which have come up, and I'm really happy for that. We'll try to address almost all of them as much as we can in the time that we have. I think it's about 20 minutes. So yeah.
Before that, we go for the Slido question.
Okay, sure. Is that okay? Let's take the Slido first.
So can everyone see the Slido? Slido.com, hashtag 1974468. The question is, which of the following are primary surveillance objectives of EPIWIN integrated surveillance? And there are several answers possible. It's not shared. It's not shared. Yeah. Right. Okay. And these are the answers we've got. So the first three are correct, and the fourth response is incorrect. Thank you very much, and over to Siti for the questions.
Okay, thank you. Well, so let's dive into the questions straight away. So quite a few of them, a lot of them are related to the standards and the implementation aspect itself. So let's take those first, and then we can take the questions which are a little more general, which go beyond the standards, more on the infection itself, be it influenza or RSV or SARS-CoV-2. So we have quite a few questions which are centered around the sample size. And just to sort of flag some of the issues that have come up is why 50? If you can also elaborate whether it's 50 per week, 50, is it based on some population for the country? There's a question around for large countries, is 50 the number? So maybe Aspen, if you, Melissa, if you would like to take that up.
Yeah, happy to take that up. So yes, the guidance recommends each week that 50 specimens from patients with ILI be tested for flu, SARS-CoV-2, and potentially RSV, and 50 specimens from patients with SARI be tested for flu, SARS-CoV-2, and possibly RSV. And those recommendations are at a national level. However, there's very good reason a country may want to monitor the respiratory illness and virus circulation at subnational levels. Thus, if a country does want to monitor at subnational levels or in subpopulations, and a really good question in the Q&A was specific to Brazil's context, where there are many states across the country of Brazil. And if Brazil as a country, as just an example, would have an objective to monitor respiratory illness in each of those states, then that sample size is really sort of recommended in all the subpopulations that you want to have represented in your national surveillance. So in many ways, countries should think about at what scale or across what geographic and demographic area it has these surveillance objectives, and scale that sampling target so that they're sampling among each of those subpopulations they really want represented in their surveillance.
Thanks. So while we are on the EPI side, there are a couple of questions around the Sentinel sites itself. So there's one question on whether, I mean, it's a thought for your opinion of whether schools should be part of Sentinel sites as part of Sentinel surveillance. That's one. Another around the Sentinel sites is whether what is there any difference in criteria while selecting ILI or SARI sites? If who would like to go for that?
I can start and then Melissa can go on. And this guidance doesn't really recommend schools as a site. This is more for healthcare facility surveillance done at healthcare facility because it really needs I think nursing staff and people who are able to collect samples and measure assess whether cases who are seen for healthcare at these facilities meet specific case definitions. So this is really, again, we're looking at really quality surveillance. So it really needs to be done consistently and with well-trained technical persons with the capacity to do this well. So currently this really focuses on healthcare facilities.
And some criteria for thinking about which sites to include as Sentinel sites, thinking about that sort of capacity to run the surveillance system consistently. You also want to think about representation and quality of the data, remembering that a good surveillance system that has a few sites that provide really consistent, good quality data may provide you more information than a lot of Sentinel surveillance sites that may not be providing quality data that you can use for situational awareness.
So on the school, let me also add, because the question was really about whether need to test the school children in the question here. So as Aspen said, that school is usually not recommended as a Sentinel sites. However, schools are really important in detecting outbreak signals. Like if in a season, whether in a season or winter season or out of winter season, there's a cluster of respiratory or even other syndromic cluster or outbreak occurs, this is really very important that you need to look into and dig down into what is the pathogen actually caused such a cluster of outbreak. And this is extremely important.
Thanks. So let's come back to the figure of 50. So there's one question on does the guidance talk about what to do in case a country is not able to reach that figure of 50, especially when it's out of season and we are recommending all year-round surveillance. So it's also related, I guess, in a way to the population density for that Sentinel network.
Yeah, I can just start again, provide my 2 cents, but it's really to look at the patterns in circulation. So really focusing on when there is activity. So there are going to be times of the year when there is no activity and won't be able to meet that target. So again, it's not it's a target, but it's not a set in stone there. So we know that there are countries of different sizes with different Sentinel systems, etc. It's not population based. But the other thing I wanted to add here too, which is sort of related, is that there are in regions, there are a lot of resources in the regions, and we know that in several regions, they are taking this guidance and adapting it to the regional context and to country-specific context. So I think, coming in the future, we should have, we will be able to further refine this and provide more tools to support this in countries with different population sizes and different characteristics.
Thanks. There's a question on the case definition. I may not have understood the question very clearly, but I understand it to say whether we need to use a SARI ILI case definition, or can we use a broader respiratory infection sort of ARI type of case definition? When we are talking of Sentinel surveillance. Aspen?
Sure. Yeah, the guidance does go into a lot of detail on which case definition to use according to different objectives, and there's a table that I showed that indicates when these case definitions may be when one or another may be important to apply, and we also understand that some countries have also made sort of a strategic change towards more expansive case definition like ARI, moving away from ILI. But I think, I think an important part is to say you can still if you have the ability to track the symptoms in those groups, you can also continue to keep track of the ILI cases as a subset of the cases in the RA surveillance. And I think this is really important to maintain continuity of data, and so you'll be able to compare current data to what you've collected previously in terms of using your baselines and thresholds as you go forward. So maybe some flexibility in the data collection when you're using different case definitions. I think this, changing case definitions should be considered not lightly, and acknowledging that any change in case definition may interfere with, again, comparing the current data to what you've collected previously.
Thanks. Let's take a couple of more questions on the EPI side, and then we move to the lab side. So this is on more on the reporting side. So there's one question around the reporting of surveillance data. Is it restricted only to GISRIS entities? So what happens if there are non-GISRIS, maybe in the public sector, outside the public sector, who have the data for any of these pathogens for surveillance data? How can they contribute, or how can they join, get the data into WHO? There's also, while you think over it, there's also another question related to the reporting. I guess it's someone from the Euro region asking whether the data that comes into TESI, how well is it aligned? Does it meet all the requirements of WHO when we pull it from TESI?
Yeah, I can address those questions. So one, the surveillance that occurs within the GISRIS system is largely facilitated by countries through their national influenza centers. And so if there's surveillance being conducted in a country that is also representative, I think the best way to address whether or not those data could be included within that would be to go to the National Influenza Center and sort of discuss that at length. I'm not going to address that further. But the question about how the reporting that's recommended within the new published guidance aligns with the TESI guidance and the reporting into the TESI system, which is specific for the European region in WHO. We work very closely with our regional colleagues, including Euro Regional Office, who also liaises very closely with ECDC, who uses and is sort of the custodian of TESI. So all that to say is these guidance have been very much developed with this full collaboration. So yes, it does actually align quite nicely with what TESI is set up to do and receive for the European region.
Yeah, so maybe let me also add a little bit more about, because we also received queries in the past, like surveillance, not necessarily within the national surveillance system, but generating data. How those data could be best used, because it is valuable itself. So our recommendation always that these independent surveillance efforts, like in the country, it would be highly recommended to be coupled or to be discussed how to include in the national reporting, to include those data generated outside of the usual system of the national operation itself. So there's no overlapping also, because this is also an important issue, but also related to the quality, sustainability, etc. These also need to be taken into consideration. So this is our recommendation. We fed back to the countries.
Thanks. Maybe we move to the lab side. I think we have a few minutes left. So Dimitri, if it's convenient, if you can put your video on. So we have some questions around the testing, the subtyping. How important is it for influenza, for specimens to be tested for type, subtype, for influenza, as well as for RSV, whether subtyping is critical?
This is actually the reason why we are running Sentinel surveillance, that we can use that minimum amount of testing and collect good amount of information on this distribution of various subtypes and lineages over the course of the epidemic. So the guidance recommends that all positive sentinel specimens being subtype and lineage determined, as well as for type 4 RSV.
So let me add a little bit more on this. Why actually we recommend, or we needed to understand different subtypes of influenza first. Because different subtypes of influenza circulating H1, H3, and B, they have the public health impact. And actually, this information is very important for us to understand, also to update vaccine composition. So although at the moment, not all the countries are subtyping influenza A, but at least they could be able to submit a subtype to understand the proportion of the influenza A, or the proportion of the A viruses circulating in the country. That's very important. Another question actually is asking about whether we need to do the lineage differentiation of B Yamagata. The lineage differentiation really important in a way, especially now, is to understand whether B Yamagata lineage emerged, but also circulating in the population. So this is very important that the countries, when they have the influenza B, they will be able to do the lineage differentiate itself. Even if they are not able to do all B lineage differentiations, they would definitely should do, so that we can be confident that there's no B Yamagata viruses emerged and circulating in the country. Coming to the ISV influenza, ISV type A and type B, it would really need to link what is the objective, whether we want to differentiate A and B in order to adapt in those countermeasures, or it is for the purpose of improve the understanding of the influenza and ISV type A and ISV type B as well. So all these options that WHO were recommending is associated with the objectives. We have very specific connection of those because we bear into our mind the resources needed in order to do that.
Thanks. So we just have a couple of minutes left. Maybe we try to quickly try to address some more questions, and rest assured we'll respond to your questions in writing post this webinar. So related to this is also the issue of multiplex vis-a-vis singleplex, the sensitivity around it. Does that compromise the use of multiplex? That's one. And another one, Dimitri, if you can take is on the CT values for sequencing. You mentioned about the standards mentioned about less than 28. Is that, can sequences also with the CT value up to 30, can they also be taken up?
Thanks, CT. So the current multiplex assay that is being provided to GISER's laboratory for simultaneous detection of influenza and SARS-CoV-2 has equal sensitivity and specificity to singleplex assays. And we would like to remind laboratories whether you use the commercial kit or the kit supplied by the GISER's system. It's very important that you perform validation and verification of your assay prior to the use. Regarding the CT value, the previous recommendation was around CT value 30. Of course, you can try and attempt sequencing, but you have higher chances of getting full genome sequencing results with samples with CT value of 28.
Thanks. I'll try to squeeze in two quick questions. So there are some questions around the transport and the storage sort of conditions that specimens that you need to ensure for specimens before when they come to the lab. If you can elaborate the -2 degrees till what they are, till how many days, and -70, etc. Maybe just a quick overview on that.
So if delivery to the laboratory and testing cannot be performed within 72 hours, then the specimen should be kept at -70, either at the deep freezer or in the liquid nitrogen. So if you are from the Sentinel side, try to find the solution, either regularly transfer samples to the laboratory, or have a -70 storage solution at your site.
Okay. Oh, thanks. So just one more question, and then we wrap it up. But that's on the CDC. What sort of support is available for RSV through this initiative, through this integrated surveillance? Just to say that, so the multiplex for RSV, which not only does RSV detection, but also types for A and B. Currently, that's available through the International Reagent Resource, but it's as of now restricted to just those countries where CDC has a coag with a particular country, or for the countries that are participating in the RSV surveillance network, which is sort of provided or given oversight by WHO GIP here. There are a lot many questions on environmental surveillance and RSV, etc., but I think we'll address them in writing over the next couple of days. And thanks again for all your questions. I also see there's a lot many questions which have popped up since I had a last look, but back to Supriya.
Thank you very much. Thank you to all the panelists and speakers. You can just see by the number of questions, we have almost 100 questions today, that there is really a lot of interest in this webinar. So I'd like to thank Wenqing City for organizing this whole thing, with Aspen, Dimitri, Melissa. And I'd also like to thank everyone who's working in the background. Kanika from Project Echo, Lester, who's been working on the chat, and everyone else who's brought this together. Before we leave, however, we have one last slide, very quickly, 1 minute. Let me see if I can share my screen. True or false, for integrated surveillance, data quantity is more important than data quality? Very, 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 very quickly. So be quick in your answers here. Same place, slido.com, hashtag 1974468. Right, we have 79 respondents, 83 respondents, 89 respondents, 90 respondents. Right, now let's see what the response has been. So most of you have got it right. 83% has got it right. It is false. And with that, thank you very much. And we look forward to seeing you at our next webinar, which is next Thursday, same time. It's on pathogen genomics for health emergencies, Spotlight Cholera. We'll talk about genomic surveillance for cholera. And thank you so much to all of you for your participation today.
Thank you.
Thank you. Oh, I love the emojis coming up. Thank you. Thank you. Bye. See you next week.